Okay, so for pharmacology, we finished the antihypertensives. So as you know, we went over hypertension pretty in depth. What are the causes of hypertension? Remember, you can have primary causes, atherosclerotic disease. You can have labile means like it can be high one day, low the next. Some things that can also arbitrarily cause hypertension is renal artery stenosis. That would be more of a secondary cause. Because remember the RAS system, right? Renin, angiotensin, aldosterone system. What triggers it? Decreased blood flow to the kidney. So if you think about it, decreased blood flow to the kidney thinks, oh, we're either hemorrhaging or we don't have enough blood volume, and it'll trigger the RAS system. And if you remember, the renin gets secreted by the kidney, goes to the liver, and the liver says, okay, I'm going to release my angiotensin. It's really angiotensinogen, and then it converts to angiotensin 1, and then it converts active formed angiotensin 2 through ACE, which is angiotensin converting enzyme that's released by the lung, and a little bit is released by the kidney. From there, it goes to angiotensin 2. Angiotensin 2 is vasoactive, causes the sympathetic system response, which we know increases heart rate, causes peripheral vasoconstriction, bronchodilation, peripheral, right? And remember your pupillary dilation, decreases the gut flow and decreases urinary outflow. We also get the peripheral vasoconstriction, can cause the erector pili muscles to constrict also, and that makes the hair stand up. But the peripheral vasoconstriction is going to cause a higher blood pressure, okay? Because remember, we want perfusion. So if you think about it, if everything's just kind of relaxed and dilated, my brain, my kidneys, you need some perfusion to get some mean arterial pressure so that it can penetrate the endothelium and actually get into the areas it needs to. So we do know that's another cause. Other causes can be other secondary causes. But if you remember also with primary, gestational hypertension, we call that preeclampsia. That can happen in pregnancy. We do know in pregnancy blood volume increases significantly. I want to say between 30 and 50% increase. So that's why they get swollen ankles and short of breath. Secondary can be a pheochromocytoma. Remember that tumor that secretes all that epinephrine and norepinephrine. So know the different causes of hypertension. We also went into the modifiable risks versus the non-modifiable, right? So do we choose who we're related to? No, right? So that's non-modifiable. What about someone that exercises? Somebody that watches what they're eating, losing weight, quitting smoking. These are things that are modifiable. Okay, so alcohol also. Okay. So think of your non-modifiables. The non-modifiables are the ones you cannot change: your sex, your age, your race, your family history. But the modifiables: diet, exercise, weight loss, and also not smoking. So think of the different medications that we talked about, right? We did talk about beta blockers, even though they're not technically on the American College of Cardiology or the American Heart Association or the GNC for primary use in hypertension, but you will see those patients that do use beta blockers for hypertension. I will accept that if you put it on there. I just want you to keep in mind it's not first line. First line is going to be your diuretics, like hydrochlorothiazide is what we're going to use. That's a thiazide diuretic. We will be talking about that down the road. Calcium channel blockers. I love amlodipine. Amlodipine's a nice vasodilator. It has a vasodilating response. Hydralazine is a true vasodilator. We can give that IV. We can also give it in pill form. Don't forget we use ACE inhibitors. ACE and ARBs, okay? We never use ACEs and ARBs, angiotensin converting enzyme, or angiotensin receptor blockers. We never use those in pregnancy. We also have limitations when they have chronic kidney disease. If their GFR goes under 30, we're very limited on what we can use for ARBs and ACEs. But they are renal protective. So if you have a patient that is diabetic, we're going to choose an ACE or an ARB. You never give an ACE and an ARB, okay? They're not given together. An Artenin is not given with a Pril. You'll either do the Pril or you do the Arten. You can add hydrochlorothiazide to that. You can do a calcium channel blocker with that. But we never give ACEs and ARBs together. There's also these selective kind of hybrid beta blocker, alpha blockers called carvedilol. We use, so if they have a reduced ejection fraction, you'll commonly see them on Coreg or carvedilol. That's a drug that is used primarily for heart failure patients to control blood pressure, but it's a very good drug, and it has to be given twice a day. So we went over beta blocker, calcium channel blockers. Remember, primarily really good use in African Americans because they don't do well with just monotherapy. So usually you have to do, with African Americans, we usually choose to do calcium channel blocker and maybe a little diuretic. The beta blockers are not on the list, but you will see them used. The ACE inhibitors and ARBs are the ones that we use for those diabetics. And if they have any chance of renal disease, they have to be on that. Remember, we don't like to give calcium channel blockers in people with significant heart failure because it can cause dilation of the vessels and it can cause edema to be worse, or it just increases that preload and they may not be able to handle all that preload. Two organs that are damaged. Think of organs that are damaged. Remember what I always say, target organ damage, TOD, diabetes and hypertension. Brain, right? Eyes. The most common dementia is vascular dementia. Then we have eyes, retinopathies. We have coronary artery disease, and we can develop nephropathies and peripheral vascular disease. So we do know with the target organ damage. So think of the organs that can be damaged from chronic hypertension. Think of medications we can give IV. So when patients come in with urgency, remember I talked about urgency and emergency. So if their blood pressure is like 180 over 100 and it's staying there, we might call that an urgency where we have to do something. And then we have an emergency, which is like 200 over 110, and we have to manage them very slowly in the hospital. And we can give like IV labetalol. That's the big one that we like to use, IV labetalol. It is also a safe drug to use in pregnancy. So remember, there's alpha blockers. Don't forget them. Okay, we do use them for hypertension, but they primarily work by relaxing the vessels. So in patients that stand up quickly, they could get dizzy and have orthostatic hypotension. Orthostatic, stand up, blood pressure drops more than 10 millimeters of mercury on the diastolic, more than 20 on the systolic, can cause them to get syncopal. So we have to also remember that alpha blockers can do that, but we reserve those alpha blockers, and examples are like terazosin, which is known as Hytrin, or tamoxifen, which is Flomax. We restrict that for patients that have benign prostate hyperplasia because of the blockage of the urinary flow, so it helps with the relaxation of the ureter sphincters to help with the urination, but it also lowers the blood pressure because it works on the alpha receptors, which are located in the bladder and in the vessels. So just be careful because they can get orthostatic hypotension really bad. I told you with ACE inhibitors, we cannot use them in patients that have renal disease where they have CKD with a GFR under 30, and we can't use it in pregnancy. So we do not use ACE inhibitors, and we don't use our angiotensin receptor blockers in pregnancy. We talked about thrombolytics and anticoagulants. So remember, with your thrombolytics, that's like your the activase, antiplase, there's all these different clot busting agents, but remember the contraindications. We have to make sure we're within the window of time. So whatever that, the window of time would be 6 hours for a stroke or a heart attack, or 4 hours, whatever the indication is, it has to be a recent kind of event. That happened, either a stroke or an MI. Also, the thrombolytics, if they're on aspirin or anticoagulation, or they had recent surgery, we will be less likely, they'll be contraindicated. I have, unfortunately, I have a question on a loop diuretic on this, because we did talk about diuretics but we didn't cover diuretics yet. But I just want you to know, loop diuretics are really bad about depleting potassium. So you always have to frequently check potassium levels with loop diuretics. But we use loop diuretics sometimes with congestive heart failure patients. We use Lasix or furosemide. Please be aware, though, that it depletes the potassium terribly. So we have to watch potassium levels. Okay, back to the anticoagulants. So warfarin, remember Coumadin's discontinued, but the generic is warfarin, and we use heparin. So if you remember, what do we monitor for the warfarin? We monitor with the PT, INR. We monitor for heparin with a PTT. Please remember the values we expect. That would be like 2 to 2.5 times the normal value. I would expect somebody with AFib to have an INR of like 2 to 3, 2.0 to 3.0. I would expect someone on heparin drip for AFib to be up to maybe 60 or 70, or up to 80 or 90 if they're having a heart attack. But if it goes over 100, we usually have to kind of stop that infusion, or they can bleed. And what do we give if they start bleeding? With warfarin, remember, we give vitamin K clots, not potassium, vitamin K that's made by the liver and the small intestine. For the heparin, we can give protamine sulfate. Okay, so these are the anticoagulants. What do we do when we're bridging patients? So they come off of their Coumadin, they have to have surgery. So we hold them for 5 to 7 days. How can we bridge them? We can give them Lovenox or enoxaparin. It's a low molecular weight. It lasts about 12 hours. Yes, we have to be careful with the kidneys. So if they have kidney disease, we can put it on a renal dosing, which means just cut the dose down to once a day. So every 24 hours versus giving enoxaparin injections sub-Q. Okay, we give them sub-Q. We would just do that twice a day. Heparin can be given sub-Q also, as long as IV. Remember, these drugs, even though it's low molecular weight, you still can't take it by mouth, okay, because the Daltons are too high. Same thing with heparin. So heparin, if we gave that IV, we just run it drip, knock it off when they go to the cath lab, or if you keep it going, that's fine. But say you give it sub-Q for bridging, they don't really do it because you have to get it every 6 hours. Okay, so the enoxaparin is good. It's given subcutaneous every 12, and most patients can handle that. So think of someone that had atrial fibrillation. They're coming in now, and they had a stent placed. So we want dual antiplatelet therapy, but we got to cover them also because they're in atrial fibrillation. So they'll be on their warfarin, or their Eliquis, or their Pradaxa, or their Xarelto, but they'll also be on dual antiplatelet, which would be what? We have Plavix, which is clopidogrel. We have Brilinta, which is ticagrelor. And why do I always forget that other new one? So we use the three. We can use any of those 3 antiplatelets. But what's the dual antiplatelet, right? The other antiplatelet is going to be your flat-out aspirin, and usually it's a baby aspirin. I know one doctor that likes. I know the one drug likes to use 325, but most of the time we have them on 81 milligrams of aspirin, and with one of their antiplatelets. So the other one is prasugrel. Okay, prasugrel is Effient, ticagrelor is Brilinta, and your clopidogrel is Plavix. So those 3 antiplatelets, one of them will be used along with a baby aspirin. And to address our atrial fibrillation, we can go ahead and we can use our drug, either warfarin, Jantivin, or the ones that don't require the testing. Remember, the ones that don't require blood tests would be your Pradaxa. I always remember it as Digitran. And then we have our Xarelto with his Rivaroxaban, and you have your Apixaban, which is your Eliquis. Okay, so if you have somebody with atrial fib and they're on anticoagulation and they had a stent placed, you're going to have 3 drugs, and 2 antiplatelet, and your anticoagulant. Please know the generics. Know the spelling on the Digitran or the Rivaroxaban or the Apixaban, because you're going to need to know that that's considered a NOAC, a novel oral anticoagulant, and the only difference is between that and warfarin and Jantivin is they don't need to get blood tests, so they're new, and we can start them right away on it, where warfarin takes a while. We can start them right away. We can stop it for 1 or 2 days and have no problems. Can they take warfarin when they're pregnant? No, they cannot. We do use, remember, first line for hypertension is your hydrochlorothiazide diuretic, and we also use it for fluid retention and heart failure. Remember, I also talked about our antiplatelet drugs. Clopidogrel often has, people can develop antibodies to clopidogrel. Okay, so if they do have that, they'll have to use a different antiplatelet, like either Effient or the Ticagrelor or the Prasugrel, which is the Effient or the Brilinta. Where do thiazides work? Thiazide diuretics, we're going to talk about this another week, but I just want you to be aware because it does have to do with hypertension. Your thiazide diuretics work in the proximal tubule. Just remember that, proximal tubule. What works in the loop of Henle is the Lasix or the furosemide, which is your loop diuretics. So that makes sense, right? Loop in the loop of Henle. Thiazides, we do get some potassium loss, but not as much as we do with the loop diuretics. But we use hydrochlorothiazide for the hypertension. That works in the proximal tubule. Remember, the carvedilol I just mentioned is kind of a hybrid. It has alpha and beta blocker qualities. Remember how calcium channel blockers work. Where do they work? Remember, peripherally. Remember our patch. Remember I talked about the patch that we use, Catapress or Clonidine. That's a patch. It's got a vasodilating kind of alpha receptor quality to it, and it's good for blood pressure, but it keeps a constant. They either keep it on for 3 days or they change it every day. I can't remember. It depends on the type. And then remember ARBs and ACEs. What is the difference? The ACE inhibitor works, and by inhibiting ACE, if you remember, angiotensin converting enzyme is actually there to protect me from coughing and coughing and coughing with all this dust, right? So if I block that, I'm going to cough a lot. And some patients can tolerate it. Sometimes it gets better after 2 weeks, but others can't tolerate it. So I want you to keep in mind that ACE inhibitors can cause a dry cough. It doesn't mean something's wrong with them, but if it's problematic, we can move them to an angiotensin receptor blocker. So that's one of the big differences with it. And do remember what they end in, right? Our ACE inhibitors end in pril. Our ARTANs, which is our angiotensin receptor blockers, end in ARTAN. Okay, we will pick up lecture. So you're going to have exam on the pharm exam. You're going to have, and we'll pick up the lecture when I get back. Okay, thanks.